Thanks everyone for allowing me to share some preliminary results that we have found related to the physical and psychological health of healthcare workforce. Now, traditionally, my background is health services research, and I'm formally trained in comparative and cost effectiveness studies related to work environment and the impact on several different outcomes. What we do know about clinician stress and burnout is that there are significant associations with clinician outcomes such as obesity, depression, anxiety, and suicides. We also know that clinician stress is directly correlated with quality of care and patient safety risks such as medical errors. And at the organizational level, we have also looked at cost and expenditures, workforce retention, and national benchmarking data. What we don't know in the context of COVID-19 is what is the impact on physical health. Things like management of pre-existing chronic conditions specific to the healthcare workforce. How is sleep, affected, activity levels, stress-related cardiovascular risk, and insomnia, as well as some psychological health risks such as anxiety, depression, and burnout. We also, there's emerging evidence about what are different strategies and stress mitigation initiatives that hospitals around the country and around the globe are trying to implement to reduce the stress and burnout in our healthcare workforce. So one of the ways that we do a lot of our health services research to approach these questions is through Donabedian's quality of care model. And the goal is to really understand the multifaceted clinical environment in which the clinician works. And that is through three linear dimensions of structure, process, and outcome. Structure would be related to resources, the infrastructure of the clinical setting, what are the teams, the team compositions and delineated roles, and then the environment and the environmental infrastructure that the clinician is working in. The process is the workflow, the responsibilities and the tasks, and then the outcome can be anything ranging from patient outcomes to organizational or clinician outcomes. So the objective overall for this study was to get some preliminary data about workforce perspectives about physical and psychological health implications of working in the COVID-19 response. Our research team was made up of all nurses. I will mention that while this was across several institutions, all of us are alumni of Columbia School of Nursing, and Dr. Oldham is a Teachers College alumni. Several of us had come together several years ago during the Ebola outbreak and also worked on several initiatives related to nursing preparedness at the time of the Ebola outbreak. And when COVID hit New York City, we decided to come together again to do some research into the lived experiences for patients and healthcare organization providers. So the methods of this particular study that I'm going to talk about today, it was conducted in a large urban hospital in Washington, D.C. It's a qualitative study. We audio recorded in-person and telephone interviews with a sample of 80 workforce, physicians, nurses, pharmacists, techs, and leadership. We also were able to interview patients, hospitalized patients that were stable enough to conduct an interview. So obviously these were not intubated patients, but patients that had were confirmed positive. We transcribed all of our interviews and then imported them into in vivo software. We conducted some inter-rater reliability statistics for coding mechanisms to develop our code book, and then we performed an inductive and deductive analysis to determine emergent themes, and then also to see how they aligned theoretically with some of the public health emergency preparedness theoretical models that exist. So this particular model that really framed our deductive analysis was the resilience framework for public health emergency preparedness by Kahn and colleagues. And these dimensions were very specific attributes of how well prepared an organization or a population is toward a public health emergency. So things like governance and leadership, what is the vertical and horizontal communication process between administration and clinicians, what kind of planning was in place, the collaborative networks that were put together to support clinicians, engagement with the community, because community engagement also can have a great impact on resilience and how someone is adapting to their environment, especially if clinicians are being deployed to settings that they are outside of their primary clinical responsibilities. Conducting a risk analysis, how we are performing surveillance and monitoring, practice and experience, and that hones in on clinical practice responsibilities, resources, including PPEs. Workforce capacity would involve knowledge and training that would prepare someone to work in the environment that they're working in. Of course, communication, and then a process for learning and evaluation if there's a deficit in knowledge that a clinician needs to be retrained in a certain aspect of clinical care. So this framework very nicely gave us a skeleton and how to approach the data. To look at an overview of the findings, and I really created a summary here for the interest of time, but reported changes in physical health. Clinicians are experiencing excessive fatigue, palpitations, and the reason palpitations is important is we know that heart rate variability over a certain amount of time can lead to increased cardiovascular risk. Surprisingly, we found no change in clinicians experiencing any changes in pre-existing chronic conditions. They reported that they were still very much aware if a clinician has a chronic condition themselves. They were extremely mindful of avoiding missing medications and adherence to care plans and staying in close touch with their providers virtually. They are reporting tremendous increase in insomnia and changes in their sleep patterns. This could have been related to changes in their scheduling or some psychological impact that was causing them to have alterations in their sleep patterns. And then also decreased physical activity and exercise. A lot of clinicians talked about the lack of time to partake in physical activity and preventative services for their own health. Reported changes in psychological health, and this kind of was the foundation of why we wanted to really perform this study, but there are high anxiety levels, generally surrounding transmission to the home and families at home, anxiety about being overcome and working in an environment that is extremely fast-paced. We did find limited depressive symptoms. So clinicians are not experiencing depression as of yet. It could be because we're still in the acute phases of our COVID response, but there was excessive worry. Surprisingly, burnout decreased according to our participants. Several reasons why this may have happened. Burnout, first of all, is usually defined as long-term exposures to stress. And in the context of COVID-19, you know, so much has happened in a short amount of time, this is still an acute phase. Also with burnout, our patient population has changed tremendously. So the roles and responsibilities of clinicians, they might have a different number of patients within their panel. They might be working with a more collaborative team. Some talked about the increased amount of teamwork has increased their sense of resilience within their practice, and they feel that they actually, in fact, have more resources to be able to cope with the demands of their job responsibilities. So interestingly enough, burnout has decreased despite high anxiety and excessive worry. One of the overarching themes that also emerged was the sense of moral fatigue. We do know there's a lot of complex ethical decisions being made, a lot of policies that in turn affect the way in which we respond, which we would otherwise respond in a different way, related to family support at the bedside, which we have not had for good reason to avoid transmission, but at the same time, This is creating a lot of moral fatigue as the clinicians are being the mediators between hospitalized patients and their loved ones outside of the hospital. Some of the strategies that are being used right now to improve clinician well-being are support groups, both virtually and on site. A lot of clinicians spoke about how important it was to understand solidarity between disciplines and understand that their feelings that they were feeling or are currently experiencing are normal and are being experienced by their fellow colleagues across all disciplines. There's also something very positive is a change in workflow to encourage on-site breaks when possible. Really important for clinicians to be able to look toward leadership at any given point throughout the day to say, I am overwhelmed, I need a break. And in turn, they have a protected space on site to take that break. Something outside of the immediate patient care setting, a place to just recuperate for a moment, get the resources that they need psychologically, and then be able to continue on with their responsibilities. Another, some of the things that are being done right now to promote positivity, and this, according to the perspectives of the workforce, is having a great impact on their own physical and psychological health, is celebrating daily goals. The daily goals are usually disseminated either via boards, like the one you see in this picture, celebrating the small, the small number of patients that are overcoming, extubation and discharges home, the number of patients that are on clinical trials. These are all positive attributes. It shows progress. And the small increment of daily progress is definitely having an impact on someone's well-being. And also the general sense of working in solidarity, not only within institutions, but across institutions. One of the things related to organizational stress mitigation resources is social
1 minute warning.
Okay, social support, effective communication and leadership, decision support access, whether that be on the internet or directly within the electronic health record, extremely clear protocols about what is expected during the patient care, and then time off for recuperation and staff scheduling. Some talked about it is very difficult to fully recuperate at home if your schedule, for example, nurses sometimes work 2 on, 1 off, 3 on, 2 off. They said it was actually better to do all shifts in one block and then have a longer period of time away from the clinical setting to recuperate. Also very important to note the impact of social media. Several clinicians acknowledged that actually social media and the messages on social media for workforce solidarity and timely exchange of information has been really supportive of their efforts. So this study, just to wrap up, this is my final slide, but this study is going to inform a large-scale quantitative survey. We've partnered with leadership from the Ryan Larkin Field Hospital, NYP and CUIMC, and NYP Allen Hospital. We're also working with military personnel in the New York Academy of Medicine to really determine the longitudinal impact on stress-related outcomes. And we're going to be looking at several different measures using several different scales, as you can see below. We're also going to triangulate our findings with physiologic measures such as heart rate, sleep, and activity levels. And overall, the overall efforts and the potential study implications of this work, we want to build evidence about organizational and team infrastructures that can optimize workforce and patient outcomes, inform the development and evaluation of stress mitigation initiatives, and overarchingly to reduce the physical and psychological health risk in our workforce. Thank you so much.
Thank you, Allison. If there are questions, please raise your hand.
I do see a question up in the chat right now about primary care physicians or ambulatory care providers. As far as I know, there are no studies right now looking at the psychological effects of this, and it's so important. And I'm hoping that the study that we are doing internally at Ryan Larkin, well, Ryan Larkin is somewhat considered, even though it's affiliated with our inpatient settings, it is ambulatory, but there is very limited evidence in the primary care setting, even before the COVID pandemic. So we're looking to apply our methodology in ambulatory care settings as well, as it's definitely taken a toll on providers across healthcare settings.
There's a question by Gary Edelstein or Edelstein. Gary, you need to unmute yourself. Otherwise, Margaret, you still have your hand raised. Do you have an additional question, or?
I think you in part answered the question, but I was going to ask if there are any comparative studies between what clinicians are experiencing and the experiences of combat soldiers. And then also to let you know that there's in fact a great deal of historical research looking at combat soldiers. And if that would be of any help to you, send me an email and I'll be happy to direct you to some of those sources.
That would be great, Margaret. What's really interesting about the Ryan Larkin Field Hospital, this is historical within itself. This is the first time that a private institution and a private hospital has come together and is collaborating with military personnel. So the Ryan Larkin Field Hospital is going to be staffed by mostly retired military physicians and medics and techs and nurses, and collaborating with our NYP staff. This is extreme. A lot of the scales that we're using haven't even been validated in military personnel. One of our specific aims of this large scale study is we're going to actually compare resilience between civilian workforce and military personnel, because we are hypothesizing that there is going to be a difference. A lot of military clinicians have had resilience training, and you know, in the private sector we haven't. So it'll be really interesting to kind of see our outcomes and validate some of these measures across different types of clinicians, and then really inform some initiatives moving forward.